Good afternoon and welcome to today's Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interest. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section and we'll make sure to ask that question for you. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Haider Asif. Dr. Asif is raised in Islamabad, Pakistan, where he also completed his medical education at Shifa College of Medicine. He is interested in pursuing a fellowship in nephrology with a strong interest in advancing into transplant nephrology in the future. Dr. Asif is passionate about improving patient outcomes through specialized kidney care. Join me in welcoming our guest speaker.
Good afternoon, everyone. Thank you for coming. Our topic for today is to discuss the future of nephrology. Nephrology as a field has been late to the party when it comes to advancements and adopting new innovation. But now, more recently, we have seen a lot of changes happening, and I think it's appropriate to be aware of what's going on in that field and what to expect in the next at least 10 years or so. So, moving forward, I don't have any financial disclosures today. Objectives of today's presentation will talk about CKD burden, transplant shortages currently in the US. We will also go over the role of AI in the field of CKD, in the field of nephrology and CKD, dialysis, transplant, as well as renal pathology. We will learn about regenerative therapies and bioartificial kidneys, and where we currently stand in that field, and we'll see what advancements are being made as far as bioartificial kidneys go. And then we will also discuss xenotransplantation, which is something the nephrology fraternity is very excited about at this time. And we'll also briefly go over home dialysis modalities. So, global CKD burden. As of 2017, which is quite a long time ago, but still 700 million people had CKD worldwide. A third of those people were in China and India, which is almost 9% of the world's population in total. The rest of the countries that I mentioned have at least 10 million cases each. And the World Health Organization says by 2040, CKD will be the 5th most common chronic kidney disease, or chronic disease. CKD burden in the US, 14% of the US adults as of now have CKD, it's around 35.5 million. By 2030, the projected will be 16.7% of the US population, which is going to increase. Part of it is due to our improved healthcare. Less people are dying of it, so prevalence increases from that as well. But overall, the incidence of CKD will also increase. So this is just a percentage of US adults 18 years and older. It's just distributed by age, sex, and ethnicity. What people have more CKD stage 1 through 4. So we can see population above the age of 65 have the highest percentage of CKD, and then it's followed by non-Hispanic blacks, and then non-Hispanic Asians and Hispanics. And then so on and so forth, as well as women have a pretty high percentage as well. So the socio-demographic index, and I'll tell you why I'm talking about that in a bit, but it's a measure of the rank of how a country or region, how developed they are, and it's based on their per capita income, their average education, and their total fertility rate in those countries. And then there's this other metric that they use, age standardized DALY rates. DALY is disability adjusted life years. They measure the overall disease burden based off of life lost due to early death, as well as lived with disability from that condition. And then ASDR is essentially the number of DALYs per 100,000 people, which would exist in the population if they have the same age structure. So it's age standardized. So countries with a high socio-demographic index, which is Europe, Eastern Europe, and then, of course, US, have a low CKD burden. And regions with a low socio-demographic index have a higher CKD burden and a higher ASDR as well, this corresponding to higher CKD. And the burden of CKD is higher among males compared to females. And I don't know exactly why that is, but probably because of the habits and lifestyle. There's a narrow gender gap between males and females in high socio-demographic index countries. This just goes to tell that already the countries with lower, and it's just an idea of how the countries who are underdeveloped have a higher CKD burden as well. They have lesser resources. They have lesser options to, diet, otherwise, and everything else that they could improve in their lifestyle. So, and then they have the higher burden of CKD just by, it just makes more sense, it's more logical. And then this is just starting from 1990 to 2021. These graphs show, this one shows the overall age prevalence from different males, females, and both sexes, as well as this is all age prevalence combined in one graph. This is all age death. So essentially we can see every graph is going in the upward direction. There's a drop from 2019 to 2021 in all age death, and then again could be attributed to our advanced healthcare, improvement in early diagnosis, newer medications coming out, and all those things. And you can see also that number of DALYs are also going up across the years from 1990 to 2021, and which are projected to continue going up. This was a model that predicted in 2021 that by 2030 we will have increase in CKD prevalence, and that's where we are at in that. So just a quick question, higher SDI corresponds to a higher CKD burden. Is that true or false? Yes, that's false. So higher SDI, a lower CKD burden, and lower SDI is higher CKD burden in those countries. Okay, moving forward to our first relevant topic of the day, AI in nephrology. Nephrology has been lagging behind in terms of adopting AI and incorporating machine learning techniques. And we have been slower, so I guess the results of that will also be slower to materialize. But AI, what does it offer in nephrology? Early diagnosis, risk prediction, personalized treatment strategies for patients. AI can use data from electronic health records, from lab results, from other genetic data to help us achieve all those things that we just talked about in terms of early diagnosis and risk prediction. And then machine learning, just briefly, is just it's machine learning essentially a machine that it's a type of program or algorithm that self-learns or improves based on prior experience and improves its performance based on that, which essentially will help us improve our treatment of patients with renal diseases. It's the use of AI, you can see it's, I think, in every field of nephrology, every sub-field of nephrology, whether it comes of AKI, CKD, dialysis, pathology, anything, it can be used in all those places. So AI in AKI, essentially, at any point, AI will not be able to prevent AKIs because most of the people who have AKIs have already developed AKIs before coming into the hospital, which is acute kidney injury, or they will have an evolving acute kidney injury, which will manifest a little bit later on. But what can AKI do? It can help us identify patients high risk for developing those AKIs once they're admitted to the hospital, or if they're outside for some reason and they're on dialysis, or, well, not on dialysis, but they're just sick from any other disease like sepsis or anything. So we can create early intervention plans based off of that risk prediction for AKI. And then Tomasev's team, they did this analysis on 700,000 patients with a deep learning-based model, and they predicted AKI in 50% of the cases with AKI and 90% of the patients with AKI requiring dialysis, which is a pretty reasonable percentage, and they predicted it 48 hours before dialysis, which is good as well, but they had a high false positive rate. So there's some work that needs to be done in that regard. The very interesting study published in ASN in 2020, they assessed patients with sepsis-associated AKI, and the AI distributed the patients into 3 different subphenotypes based off of their lab values, their presentation, notes, all those things combined, and which was very interesting because the outcome data from that in terms of mortality at 28 days as well as after AKI and dialysis requirement was different in all those 3 subphenotypes. And then there is this other study done in 2021, a randomized controlled trial of 6,000 patients. They used this clinical decision support system. This is another form of the AI algorithm. And they used pop-up alerts in the EHRs, but it did not show any improvement in length of stay or mortality. So this is just that study I was talking about with sepsis-associated AKI. There are 3 subphenotypes. They had almost 4,000 patients in this study. The least amount were in the S3 phenotype, but you can see that the 28-day mortality was the highest in that, as well as the dialysis requirement was highest in the S3 phenotype. So basically, AI has been proven, it has shown potential in AKI, at least risk prediction, and we can probably initiate early interventions based off of what those models predict. Of course, we are still long ways from that. In CKD patients, AI has, essentially AI can help predict the risk of CKD progression in patients who have comorbidities and other issues going on along with their CKD. But generally, CKD is very under-recognized, it's under-reported, we don't screen that much, and even when we have patients in our clinics, they are not, it's not something, a lot of times I've seen they're not aware of their CKD. And one of the very common questions I see when a patient is notified that they have CKD stage 3A, patients do ask that, will I need dialysis? Will I end up, when will I end up needing dialysis? Or will it get worse or not? It's a very common question, especially in the primary care clinics, even in nephrology clinics as well. And there's no right or wrong answer to that question because nobody knows. There's an idea that you have 1 ml per kg decline per year or 1 ml per minute decline in your GFR every year, but that's just there, and you cannot predict based off of how their lifestyle is, what other comorbidities are in play, what some out of the blue they may develop some infection, sepsis, which could just aggravate their CKD progression much faster. So we don't have all those, and that I think always will be up in the air. There will be no definitive way to address that part, the uncertainty in that area. But in patients who have CKD, we can apply AI in that regard to assess how much risk they have of CKD progression. The models that have been used so far have had reasonable accuracy, good specificity as well, but not a good sensitivity in that regard. So new treatment pathways will open with AI. So this is this meta-analysis which was published last year in December of 33 studies done across the world. All of these studies use different AI tools for training and testing purposes, but they used patient demographics, lab data, other images, and their other chronic issues along with that. They had 2 of those AI algorithms predicted CKD progression by 99 or 100% in both of those, which is promising. So that's the accuracy and efficacy of this so far. We'll see where that goes, but so so far, all these studies individually showed a very high specificity and low sensitivity. The goal, of course, will be to have the models should have high sensitivity as well as high specificity to be reliable. A lot of heterogeneity in their performance across populations, which is understandable because different AI models, different populations, there needs to be a more standardized way to deal with that. Another meta-analysis was done which showed a good area under curve of 0.82, and then specificity, again, you can see was 0.84, but sensitivity was 0.64, which is not as good. Same goes for this other systematic review. It showed high accuracy, high sensitivity, and specificity as well, but again, it's not reliable, it's not consistent with the other data that we have. So overall, the prospect of AKI in CKD is promising. This is one of the trials which was done back in 2019 by Mr. Makino's team. 64,000 patients with diabetic kidney disease were basically their risk of diabetic kidney disease progression was assessed. And they used albuminuria and some other markers, and it had an accuracy of 71%, which is pretty good. Same goes for this model. This is a clean risk machine model. They used it in Canvas and Credence trials. Credence trial was the one which evaluated the benefit of SGLT2s in CKD patients, and the Canvas was the one which did the SGLT2s for CKD as well as cardiovascular mortality. So they used the patient population and data from that one, and they applied this model to that, and it had very high accuracy in prediction of CKD progression in those patients. So this is a company, Renaltix AI, which used this model called Kidney Intel X to assist in managing diabetic kidney disease. And they use several biomarkers and a lot of other factors that are involved in it. And they were able to predict a decline in kidney function over 5 years. And it did that with the C statistic, which is a measure of to discriminate between case and controls of how good it is, and it was 0.77, which is also pretty good. And another study this model is being used on is 1 year pre and post-test clinical impact on care management, eGFR slope, which is the downtrend in eGFR, and then A1C in 5,000 patients. Basically, the model resulted in escalation for patients who were at high risk of progression by increasing the efforts of starting them on SGLT2s, GLP-1s, or specialist referrals. The AI model was able to help with and predict that this patient is at risk of decline in kidney function, so we need to initiate measures to prevent that, and it was pretty good with that. So improvement in cardiometabolic kidney health from that. So the conclusion as far as AI goes in CKD, we have good potential. We have we can incorporate that into our practice, hopefully in the future. There's a lot of barriers which need to be addressed, which we'll talk about later, and that's across the board in all these diseases that we are discussing. But that's the issue with AI in general. But future research we need to focus on, we need to have standardized predictors, we need to have consistency across populations, because if we use an AI model, it will be different in a population in Africa or in US probably, and then in Asia as well. So we need to have those predictors set out for AI models. We may have different AI models in different countries, but at least we can, wherever they are, we can have them standardized at that place so that they can be used in the future to reduce the CKD burden globally, especially in the US as well. So most AI models for CKD progression have proven to have high specificity and low sensitivity. Is that true or false?
True.
True? Yes, that's correct. So AI and dialysis. Dialysis is a very standardized process in the US and across the world as well. There's a lot of objective data that goes into dialysis machines. It's very attractive from an AI perspective. You can incorporate all that data, let AI decide or figure out what's the best plan moving forward, or at least help us in that context. So, and the data in a dialysis machine itself, the nursing charting, the physician charting, and all that goes together to help AI. So, how can AI help in that process? So Mr. Chan's group used this AI model called natural language processing into EHRs, and basically it was assessing symptom burden in dialysis patients. It was comparing itself against ICD-10 code, which is what diagnosis codes we enter in patients. So essentially, the nephrologists who were entering those ICD-10 codes, it's compared with EHR's diagnosis or EHR's assessment, or sorry, AI's assessment in that EHR for that symptom burden. It was nausea, vomiting, cramping, hypotension in those patients. And it was actually better, had a higher sensitivity compared with the physicians who were doing it, because it was using nursing charting, it was using patient charts, it was using, the physician charting, it was using all the lab data and everything else in that context. And what the ICD-10 codes were entered by the physicians were just the symptoms they documented. Sometimes we miss them, sometimes we don't think they're as important, but nurses and everything else combined, AI is able to it can perform more complex analysis in that regard. Mr. Zhang's group did an image analysis, which is not so related with dialysis, but the vascular access analysis of the image. It was showing that the aneurysm, whether it's classified as non-advanced or advanced, and this was measured against other physicians, and it had an accuracy of, or area under the curve of 0.96, which is also pretty good. In other retrospective study, they used data from over 260,000 patients, and then this model predicted intradialytic hypotension with an AUC of 0.94, which is also pretty good. So this is just the very basic of it, and then when we go forward, this is another study that was done, and it was a study done in 2016, which the AI model was used to predict the risk of hospitalization in outpatient HD patients. And the predictive model used all the treatment history, the nursing assessments, the hospitalization history in the past, and anybody with more than 6 hospitalization risk in a year was flagged by AI, and it was going to initiate measures such as activating an interdisciplinary team, nutritionists, the social workers to help them if they have like transportation issues to dialysis sessions, make sure they're getting adequate nutrition, they're coming for their anemia treatment and whatever else is needed from that standpoint. And you can clearly see that the control was the one which did not involve the AI, and in the orange, this is the DHRP, which is Dialysis Hospitalization Reduction Program, which was called. And there's at least, this is hospital admission days and hospital admission rate in that from 2016 to 2018, which is lower at least by 1 day across the patients. So that's pretty impressive, how AI can help initiate that. And in the future, if we are able to, we can develop better models and better AI tools to assist in this. And I think more than 6 hospitalizations we can even have reduced that even more if we have. But of course, it will require a lot of resources to be employed in this aspect. And there's a lot of hospital admissions we see for dialysis patients due to non-compliance and other issues as well. So challenges that we will see: lack of regulations. The data privacy is a huge is a question. There's some ethical issues surrounding that, and then we have been slow in integrating into the practice for clinicians, and then they don't adopt that in their daily workflow. It's just very slow, the whole process. Machine learning, the black box is essentially we don't know how these AI models reach their conclusion. And that's across the board in all these AI algorithms. This is something it's a concern for all physicians in general, just because if we don't know how the AI reached, we're not able to trust it. And if we're not able to trust that conclusion, how that AI reached that conclusion, we will always feel a little, will not be comfortable in incorporating that into practice unless so that's something that needs to be addressed in the future. And this goes again for AI in CKD models or anything else as well. Technical expertise we need in terms of these analyzing these data and into the machines, feeding them into the models and out of them and interpreting them. All that stuff needs to be, there's a lot of technical expertise around that which needs to be dealt with. As far as AI models, again, we discussed in different populations, even across the US, different ethnicities might have different AI models for them, or I can't say for sure, but in general, at least across different countries, different risk predictors, different comorbidities in patients will also have various different implications to that AI model. Dialysis settings will be different in countries. They have so many different sort of machines that we'll use, so we have to have that as well, and it will be one of the barriers to address in the future as well for proper implementation of AI in dialysis. AI in renal pathology. AI has been a huge part of pathology in general as far as oncology goes. They have incorporated that, and now nephropathology has also been using these deep learning models to help them. It's not very common as yet, but we are getting to that point where more recently, the prognostic features of kidney histology it has been segmented into different areas through AI. And then YSS group investigated the potential value of the machine learning in recognition of glomerular morphologic changes, amyloidosis, and other issues. This other group were able to distinguish between normal and abnormal renal tubules as well, which is also good. As far as transplant goes, any patient receiving transplant or any donor kidney that's available has to have a pre-implantation biopsy. Now, most of the times, it's an urgent situation, and an on-call pathologist will get a call that there's this availability of this kidney, and this is the pathology, and what do we do? It needs to have, even pathologists, not every pathologist is trained, so nephropathologists have to be, it's a more niche and more specific kind of field, so somebody may have expertise or not in that area. If we are able to train the AI model specifically to assess that, what the post-transplant prognosis of the patient would be with that kidney, we'll be able to either allocate it or discard that kidney based off of that. Of course, we need to be, if we are going to make that decision, we have to be very certain that the AI model is good, because we don't want to lose a kidney or just because of the AI said that. So that's one thing that could be used in the future, and it could expedite the process of organ allocation down the line. And even in the field of nephro-oncology, as other oncology fields, it is very promising in terms of differentiating different subtypes of cancer like clear cell, papillary renal cell carcinoma, as well as chromophobe renal cell carcinoma. In the field of renal pathology as well, it's pretty good. This 3D digital pathology is another interesting thing. This team described a new technology where multiple 2D slides could be placed together to create a 3D image of that resected tissue, which could give the pathologist a complete 3D view of the area or the tissue which was biopsied, which is of course promising. Although there's more research that needs to be done around it. There's not much data and not much done, but at least that's a prospect that we can look into down the line as well, having 3D images of these pathology. Moving forward, integration of AI with other clinical data. So this is, again, with respect to pathology analysis. The renal pathology is very a basic thing. If a pathologist is reading an image, if they have data behind what the patient comorbidities are, the EHR data, the clinical notes and everything, and AI can incorporate all that information into that, and then it can help improve patient outcomes in general. It will help decision-making for the pathologist, for the patient, as well as helping in, I think, diagnosis what's going on. A lot of the times, pathology imaging is not absolutely certain of what it is. So at least some idea behind what's going on behind the scenes will help with that as well. This is just a picture of how it's done, manual labeling, and then they train the network, and then there's deploying of the images. Again, limitations, same. We have the algorithms. We need to have more standardized algorithms. There's issue with data privacy. There's issue with black box. And then, of course, ethical and safety issues. And we'll move forward from this. Conclusion, yeah, it's promising. It's going to be helpful in terms of improving patient outcomes, most importantly, the renal pathology, or just the pathologists in general across the board in pathology and in specific renal pathology, AI will help reduce their workload a lot. In transplant, more than 260,000 Americans are living with the transplant. 90,000 Americans are on the wait list right now, and only 1/4 or 1 in 4 people are able to get the kidney. Almost 6,500 transplants are performed in the US last year. The shortage of this donor kidneys means more patients will be needing dialysis, of course. So this is just a study done to predict, this is what's called iBox was the model, the AI model which was used, in long-term risk of allograft failure. It was predicting that in the transplant patients, what's the long-term risk of that, the donor kidney failing, or whether rejection or whatever it was. So this was the first image right here this is the iBox. As you can see, it has a pretty good probability. And then this is the residents, this is the fellows, this is the nephrologists. Resident too did better than most of the people here, but that just goes to show that it's not a very hard and fast way. There's no criteria, there's no reasonable assessment in terms of it's just a hit or a miss in terms of when it comes to assessment of when the allograft failure, what's the risk of that. Some people can do it better than the others, but the AI model predicted it very well. So in terms of transplant, it again has good opportunities to, and then we already discussed in renal pathology that the donor transplant, assessing that whether the donor kidney needs to be allocated or discarded, and what the post-transplant prognosis of the patient would be, AI would help with that, and that essentially also goes within the transplant domain. And then there's this other models that decide whether to accept or reject kidneys. Again, as we said, it helps the patients. And they have these scores which they use, kidney profile index and others. So again, in general, challenges in AI, standardization, we need to have standardized parameters or metrics that the AI needs to be trained on across the board. There are different AI models being used, and the studies that we did probably had like 10 different models that were used across the board. So in terms of standardizing that and having more consistency, we need to have some at least few AI models which are more standard for everything. Black box, huge issue. For the comfort of the physicians to accept this, we will need to address that. Safety, efficacy, data, bias, all those things will need to be addressed in the future as well. So there's a lot to figure out in terms of AI in all these fields, but I guess more research, more funding is needed for research, for validation studies for these. We need to train the nephrologists in using AI and being able to incorporate AI in the curriculum, especially in fellowship training as well. Then the nephrology fellows need to be trained in the use of AI and be more comfortable with it. We need to have more studies, of course, in safety, efficacy, do more clinical trials, avoid bias. Medical workforce needs to be trained very well, and then, of course, there's ethical issues that need to be addressed in terms of data privacy and transparency. So we're moving on to regenerative therapies in the interest of time. A lot to cover for now, but regenerative therapies are essentially, it's a promising field in healthcare for now. It focuses on helping kidneys repair themselves. There's two main processes of regeneration. Intrinsic, which is the natural ability of the kidney to restore its function, and then exogenous or extrinsic, which we will talk about extrinsic mainly here. There are stem cell-based therapies, embryonic stem cells and adult stem cells, 3 different types of adult stem cells, and then their prospects in terms of differentiation into kidney cells as well as endocrine effect and kidney organoids. embryonic stem cells, they have the ability to differentiate into any cell in the body, and but there's ethical issues surrounding these embryonic stem cells, and since they are also taken from different patients, so they express antigens and they're prone to rejection as well. So that's the, and so there's not much research going on this side, but more on the other side of the right side of that table that I showed earlier. So induced pluripotent stem cells, they can be obtained from umbilical cord, peripheral blood, keratinocytes. They can be obtained from mesangial cells in the renal tubules, as well as renal epithelial cells. Induced pluripotent stem cells, or iPSCs, explored in many different, they have been able to do that, to create three-dimensional structures, which is essentially kidney organoids, which we'll discuss later on. They have been able to do that with these cells as well. This Toyohara's group established a protocol to use these stem cells and construct a three-dimensional renal tubule-like structure as well in vitro. Several other groups also use this to derive kidney organoids, and which essentially the organoid that was created had nephron segments, glomerulus, proximal tubule, loop of Henle, and distal tubule, and as well as other things. But there's still, of course, a lot of research going on in this domain, and it's not something that's just substantial, that's out there, that everything that's been done is working the way it's supposed to. Endothelial progenitor cells, they are again isolated from bone marrow, cord blood, peripheral blood. They have been used in animal models where AKI was induced, and they injected them with EPCs, and there was decrease in serum creatinine and albuminuria, which is also a good sign. Again, this other group demonstrated this against serum creatinine and reduced progression of CKD in that patient's population. Mr. Huang's group demonstrated inhibition of CKD progression as well in a rodent model. They used blood-derived EPCs. Again, the difference between different derived, these cells are derived from different sources, and again, from all those different sources, the efficacy is also different. Mesenchymal stromal cells were first discovered from bone marrow, and then they are obtained from umbilical cord, they are obtained from placenta, and many other sources as well. They have been shown the most potential in terms of regenerating the damaged kidneys. And so far, they have been used in animal models with AKI and CKD, and they have been more than, a systemic review of 70 articles shows that they were the most effective cell population. There's some issues with this. They are advancing these trials, but more than 40 clinical trials are going on right now in terms of using stem cell-based therapies in kidney diseases, and that's been registered so far. The first few trials used from different sources, and then Mr. Swaminathan's group found a contrasting finding where they said that it did not decrease time to recovery of any kidney function or patients with a developed stage of AKI after cardiac surgery. So essentially, some studies showed the efficacy, some studies did not. This is a pilot study done on adipose-derived MSCs for patients with CKD, and the cells were safe, but there was no adverse effects. At the same time, improvement in the urinary protein excretion was seen in that population as well. This other group as well, they used bone marrow derived MSCs, and they also showed some, they said no significant change in GFR or serum creatinine during the 18 months. So the data is not very, it's not either this or that side, so we need to do more studies. The issue with human clinical application is that the physiology of the animals is much different than the humans, so that's one huge aspect of it. Then the rejection aspect, where the human immune system works very differently than the animals, so that's another issue that will come in this field down the line, as well as they need to, the demographics of the patient, like age, sex, comorbidities, everything else goes on to contribute to a patient in a human model than an animal. All those things are not accounted for, and these induced kidney injuries are unphysiological as well, so that's another question. So how well it would play out in the humans is, again, uncertain. Kidney organoids, as we discussed, the PSCs can be, kidney organoids are just kidneys that's created through stem cell therapy, and that potentially the idea is it can be transplanted into humans in the future, which would be very promising if we are able to do that. It would be a huge breakthrough if we are able to create a kidney organoid. There's the big factor is that when they use these cells, the cells usually self-organize, and there's no way to control these cells as of yet in terms of their organization into the kidney tubules, and that's one of the barriers. Then, of course, there's safety and efficacy and a lot of ethical considerations surrounding this. So kidney organoids are something to look out for in the next, I would say, 10 years. But for now, we need a lot of research in this category. Bioartificial kidneys are different. It's basically an artificial kidney that could be implanted into the patients. Very promising in the future as well. Silicon nanotechnology with an engineering device. It has a bioreactor inside which mimics the kidney's endocrine and metabolic function. We can use the iliac vessels, and it can be incorporated into it's just placed in the human body. It's very interesting how it would be done in the future. This is like just a brief idea of different modalities that include variable artificial kidneys as well as bioartificial kidneys. The implantable or variable and implantable. So this is xenotransplantation, which we'll talk about later, but hemodialysis, you can see the number of cans reflects how much dialysate is used in a hemodialysis patient. So that's a lot right here in the HD patient. This is a portable HD where the dialysate circuit is closed, and but still there's extracorporeal blood has to, extracorporeal blood circuit is out there still. But the dialysate used is very less, and which of course contributes to overall cost of the dialysis as well. Same with peritoneal dialysis, you can see that it used dialysate, and this again has a closed circuit with dialysate here, and then that also will be more cost effective. The implantable dialysis filter will be implanted in there. It's not something that's done as yet, but it will also have a dialysate circuit which will be outside of the body, but blood circuit there'll not be any blood circuit. And then this is the artificial kidney, no dialysate needed. It will just use the human blood, and it will everything will be inside that implantable kidney. So designers have a lot of issues to face. Of course, the human kidney is very intricate. It performs so many functions. What function they will need to have in the implantable kidneys. I'm again only talking about implantable artificial kidneys. The variable is a different thing. What they can incorporate into that machine is again still a question. They have to have blood compatibility. Heparin is not very promising in the long term to preventing the kidney from clotting. So overall, the idea would be to conduct more research into getting these implantable artificial kidneys to have better coating in terms of preventing them from clogging, more biosafety from that aspect, as well as better filtration and what other functions are we are having. We need to get blood pressure under control. Kidneys produce erythropoietin. They have endocrine function. They have other issues. So what are we trying to achieve would be the big question down the line. Currently, they have not yet started human clinical trials, but the device that they made have series of membranes which filter blood. There's the bioreactor which performs the metabolic endocrinological functions, and then silicone membranes have been used or suggested to prevent to improve the biocompatibility with blood, which is in pigs and rats so far, but we'll see how that turns out in the future. So again, challenges need to have a good filter. They need to have a good idea of the cell mass and total surface area of the implantable kidney that they're going to use to be able to perform the function of a normal kidneys. They need to have, of course, economically viable things going on. They need to have this. It might not be in the long run. It might be economically viable if the dialysis cost and everything else is included. that's to say when we are able to achieve this remarkable feat. And then so far the biocompatibility and then other issues they need to address in the future as well. As far as briefly talking about wearable artificial kidneys goes, they are closer in time in that context because they don't have to have that much of they don't need as much advancement or as much issues with it, because you can still have an extracorporeal blood circuit with that. So you don't have the issues of biocompatibility in a lot of those scenarios. They will be able to, there's still research going on. We don't know exactly how long it will take, but probably we can expect this as well sooner than implantable artificial kidneys, maybe in the next 5 to 10 years or so. Renal transplant, at any given time, again, we discussed this like multiple times, 90,000 people in the US are waiting for transplant. Only 1 in 4 get them. 11 people die waiting for the transplant. 78% of the patients who are on chronic HD at 1 year have survival of patients with chronic HD at 78% at 1 year, and then 57% at 3 years, and 42%. 40% of the patients who are waitlisted will probably die, and those who will die will probably be good candidates of this transplant when they were listed. Again, this is just the data from September 2024 of the patients that are there for all the transplants, and then you can see the highest is kidney transplants, and most of the patients got the kidney transplant within that. That was from September 2024 as well as, and yeah, so almost 1 in 4 people are getting it, and there's still long ways to go. So the reason we talked about that is because this field, which is, as I said, the nephrology fraternity is very excited about xenotransplantation, because recently a lot of advancements have been made in this context, which we'll talk about in a bit. Essentially, xenotransplantation is transplantation of an organ from any other species to a different one. Xenotransplantation of the kidney would, of course, refer to a transplantation of the kidney, which will lead to unlimited supply of organs, and it's at this time it's only being considered in pigs. The high cost and high specialization makes this technique much more feasible in very few centers worldwide, and if you talk about the US, only a few places have done this so far, just because of the specialization that's needed. When I was going through this, I realized why don't they have like why these folks seem much closer to us from an evolutionary standpoint than anything else. So interestingly, in 1963, they did this. 6 patients were transplanted with chimpanzee kidneys, which was way back, and they figured out that within 8 weeks, everybody succumbed to either rejection or infection or something else was going on. 1 patient survived 9 months, went back to work as a school teacher, but then died from electrolyte imbalance. Apparently, the kidneys was not as good as regulating the electrolyte balance as a human kidney. And then baboon and monkey kidneys were even less successful. It was 1980s, they decided that non-human primates are not the best way to go. Maybe pig kidneys are more feasible. And again, there's some ethical challenges surrounding that as well. Pigs are more available, I would say, and then it just doesn't feel right, I would say. So historical aspects, transplantation. Interestingly, the first one done was in 1838. And it was unsurprisingly not successful. They did a cornea transplant from a pig cornea to a human back then. And then the timeline in the US of this progress is 1960s, these non-human primates were tested, which failed. And then 1990s, pigs became the choice. In 2019, they transplanted a pig kidney in a macaque, which is a monkey, type of a monkey, and that it survived more than a year in that monkey. And then in September 2021, the UAB did this successful transplant in a genetically modified pig kidney into a brain-dead human. And then NYU Langone also did one in 2 brain-dead humans in September of 2021. In January 2022, University of Maryland did another one, modified pig heart into a living recipient. The recipient passed away within months, but they don't they didn't think it was due to transplant. In June 2022 and July 2022, and Langone Health did another one. They did into deceased humans and to gather data, and that was also there. And then MGH did successful transplant on a genetically edited pig kidney. And this gentleman also passed away later on, but again, transplant did not play a death, apparently, in that case as well. You can see most of these cases are done either UAB, either Mass General or NYU. We have much bigger centers, but again, the expertise required in this is very limited, and so only a few places have. And NYU did this, another one, and then heart and pump pig kidney transplant, which also patient did not survive later on, probably due to, it was attributed to the LVAD failure. Or some issues with the LVAD. Most recent developments, November 2024, there was this lady in Alabama who had done she received a pig kidney in November, and she did well until April 2025, but then she succumbed to rejection, and it was supposedly due to her getting an infection, and they had to reduce the dose of the immunosuppressives, and that resulted in failure of the organ. In January 2025, this gentleman right here received a pig kidney, and he was 66 years old, 2 years on dialysis, and he apparently is living and doing well. So that's that. We'll see how that goes. So what lies ahead? FDA has given green light to 2 clinical trials. One of them is this company, United Therapeutics. They have 50 patients enrolled as yet for this. And there's a set criteria between ages between 55 and 70. The patients will not receive unlikely to receive any deceased donor transplants within 5 years, and other criteria which will be, and then over a 24-week post-transplant follow-up period, they will assess the patients for kidney function, quality of life, and other. And then this other company, eGenesis, also received approval for, I think, three pig kidneys into patients, which they can do. And then we will see how that goes. But again, the challenge is rejection is a big thing. There's still not what gene editing is required in the pigs, what immunosuppression will be ideal for this to prevent the rejection is one thing. Physiologically, what functions kidneys can perform? Can they regulate blood pressure? Can they perform the RAS system functions? Can they do the erythropoietin? Or everything else is a big question as well out there. So there'll be challenges. Biosafety-wise, yes, there's been no reports as yet of pig viruses within the human going with a transplanted organ, but it doesn't necessarily mean that it will not happen. There's a lot of endogenous pig viruses which can be transplanted with the kidney, and that's something to look out for in the future as well. And then, of course, there's ethical and social, or not ethical, but social issues as well. In the part of the world I come from, I'm pretty sure people will not be very comfortable with pig kidneys in them. Social stigma and a lot of religious factors as well. I believe people in the US as well. NKF did in 1999, they did this analysis just across the country whether patients will do it, and everybody said that they will be okay with the pig kidney, but they would prefer, of course, a human kidney before, but if there's not any option or chance of that, then they'll probably be fine with it. But that's one thing that will be there down the line. So there's a lot of enthusiasm, there's a lot of excitement about it, but there's a long ways to go, I would say. But in the next 10 years, I would say we'll be very close to this. Lastly, home dialysis. 2 of the main home dialysis modalities are peritoneal dialysis and hemodialysis, or home hemodialysis, which is something that's recently or more recently started. Peritoneal dialysis is a little older or much older than this, but this is something that needs to be more, patients need to be more educated on this, and I think earlier education needs to be done because not everybody is aware of this. Again, peritoneal dialysis, we'll talk about it first. Now the conclusion is that every patient who would end up on dialysis should be offered peritoneal dialysis first if they are a candidate, and that's because there's better quality of life. There's more, more flexibility with it. There's lower cost associated with it, and a lot of other benefits as well. So that's something that nephrologists are moving towards it, and they want to enforce that more. But unfortunately, it's not as common out there. So again, there's two forms of it, and patients can do it themselves, continuous ambulatory PD, where they can just insert the dialysate, leave it there for a few hours, take it out themselves, or that doesn't require any machine. And then the automated PD requires a machine which will cycle the dialysate and remove it by themselves, which can be done overnight when they're sleeping. So essentially, it's pretty good. And the machines are very portable. They can take them, they can travel with them. They don't have to depend on every other day of dialysis in center. Same goes so home hemodialysis machines they're coming in this short size. They can fit on your nightstand, and it's pretty good in terms of they're not a candidate for PD, because after 5 or 6 years of PD or so, the peritoneal membrane is not good enough. There's scarring. So you eventually, if you don't get, or you're not a candidate for transplant, you will end up on HD anyway. So so home hemodialysis works the same way, but of course much less dialysate is used, and it's much more cost friendly. And again, you can also travel with it as well, and much more gentler. You have more flexibility. So benefits, again, flexibility. You can do it in the comfort of your home. You can move anywhere you want to. You have better quality of life. Outcomes, patient can do much better and maybe be a transplant candidate for a longer period of time if they are able to stay healthy enough. They can keep their employment. So a lot of convenience associated with this. And then lastly, I would say the barriers. Training is the huge issue, to summarize this whole thing. Patients need to be trained. They need to have social support to do dialysis at home. People who don't, usually they're very overwhelmed and reluctant by the whole process. So we need to start the training early. We need to educate them early. We need to avoid the time delay, because the longer the delay happens, the more likely the patient is not to go on home dialysis or peritoneal dialysis or any other modality for that matter. So that's that. So the only reason in-center HD is preferable over home hemodialysis is due to the higher cost of home hemodialysis. True or false?
False.
Yeah, a home hemodialysis will be much cheaper. So that's that. And special thanks to Dr. Gross and Dr. Coendo. These are my references, and thank you all. I'll take any questions.
Thank you so much for that amazing presentation, and it was very insightful. But I did have a quick question about if you came across more about lab-grown kidneys. Is it related to the stem cell process that you mentioned, or is there a little bit more?
I didn't get the question again, say it again.
Like lab-grown kidneys?
Oh, the kidney organoids.
Yeah.
Yeah, so what's the question?
How effective were they? I guess like
they have not been able to actually accomplish that as yet. They have not actually done the transplantation of that. They're studying it they're trying to study it in first animal models to see how that would be effective. There's not much data surrounding that as yet, because they have not been able to. They're more focused on the other stem cell therapies. Kidney organoids are I think, if anything that's furthest from all of this that I just mentioned, probably would be kidney organoids, because there's a lot more intricacies involved in actually developing it when it goes to controlling the cellular differentiation into all those different parts of the kidney. There's long ways to it. So they have not actually done that right now. They're figuring out all those issues, but something that we can hope to have in the future.
Thank you so much.
Thank you for the presentation. I have a question. Have you found any research with any, I guess, animals that have been studied that could replace, pigs? Because I'm sure religious reasons, or just, I guess, maybe a more dignified animal would be better acceptable by many.
That's a good question. Honestly, they did not. I don't think they even gave any other animal a chance. but if you look back, 1963 was a long time ago. pretty sure immunosuppression back then was much more less, and they did like those non-human primates. I would say 9 months was I think 9 months surviving on that kidney was the longest anybody has survived on any kidney as yet. Even counting this gentleman that I just showed here who got it in February this year, or January. So I would say it was not as unsuccessful in the past, the non-human primates, but again, the availability and ethical issues, I think, have also been a big challenge. I would say they have not tried anything as yet, but it would be an option if pig kidneys don't make it, which is, again, we'll wait and see. Nothing right now.
Thank you, Dr. Asif.
Thank you.